Please.
Okay,
Yes.
after my countdown, sir.
Are we live?
So it's 3, 2, 1. We are live to the attendees platform. We can start this meeting. Over to you, Rajesh, sir.
Yeah. A very warm good evening once again from the Cochin Safe Skills Academy. And we are happy to have our second edition of the Journal Watch, which is intended to refresh what is happening contemporarily in respiratory medicine and related critical care across the globe. And we are selecting some of the landmark articles which we thought would be appealing and which would be relevant for day-to-day practice in respiratory medicine and critical care. And we have selected it as 2 sessions as Journal Watch, one major journal which will be appraised by Dr. Thomas Kurian, chaired by Dr. Paramesh. And secondly, a set of articles which will be reviewed by Dr. Sajida, which will be chaired by Dr. Praveen Valsalan. And we have one sponsored session also in this particular edition. For some technical reasons, I'll be starting with the sponsored session first. And I would like to place sincere gratitude to all directors of Cochin Safe Skills Academy, Dr. Rooney, Dr. Srivalsan, and all the faculties who have been core supporters of Cochin Safe Skills. To be very precise, Dr. Praveen Valsalan, Dr. Paramesh, Dr. Asmita, Dr. Akhilesh, Dr. Subin, Dr. Thomas, and we have a very special faculty as a guest today, Dr. Sajida from Kottayam Medical College. So a very warm welcome to all of you. And we'll start off with the sponsored session first, and I request Dr. Srivalsan to just have a few words on that before I start off.
Yeah. Good evening, everyone, and thank you, Rajesh. So, as Rajesh already told, today we have 3 sessions. And the first talk will be by Dr. Rajesh himself, and that is on multi-drug resistant gram-negative infections, with a special focus on ceftazidime avibactam. So we all know that in our current practice, we come across carbapenem-resistant bugs quite frequently. It is not uncommon to see a carbapenem-resistant bug in our ICUs nowadays. And there is a lot of confusion regarding the use of when the optimally the ceftazidime avibactam can be utilized in these infections. And there is a lot of misunderstanding as well among the clinicians, because many of them think that this is the ultimate answer for every carbapenem-resistant infection. But the fact is that it can be used only selectively, that too based on our culture and sensitivity report, or either based on our PCR reports. And it cannot be used in some of the infections like Pseudomonas and Acinetobacter mostly. In some of the Pseudomonas, it can be used, but it cannot be considered in Acinetobacter infections at all. So whatever it is, it can be mainly used only in Enterobacter. So there is a lot of confusion regarding it. So it is now the patent period of the original disease molecule is over, and a lot of companies are in the market, and there is a threat that there is a possibility that it is misuse. A possibility of misuse is there because of so many companies are competing for the space. So I think this topic is quite relevant at this particular context, and I invite Dr. Rajesh to deliver the talk. Thank you.
I hope my slides are visible.
Yes, sir, it's visible.
Full screen moving.
Full screen is also there, moving also. Thank you, sir.
So thank you, Srivalsan. I think your one comment is very relevant, that with the upliftment of the patency, a lot of companies have started launching these, and there may be a potential that many of them will slash their price to the extent that less informed clinician might actually abuse it. So that's the real threat. With these words, I will just have a very short discussion on the multi-drug resistance in gram-negative bacillary infections approach to diagnosis and therapy. And I will I would stick myself basically to lung infections with a very rough outline of extrapulmonary infections, and there is no mention of gram-positive cocci in this lecture. So we'll try to define ESBLs, MDR, PDR, etc., the mechanisms and detection of resistance, the treatment options, the IDSA 2021 guidelines, some specific drugs, and selected evidences on the newer agents. So if I am asked as what is the best resistance of multi and pan drug resistance, there are variable definitions used in different studies, but the most accepted and appropriate definition for MDR would be resistance to representative antibiotics of three major antibiotic classes like the anti-pseudomonal penicillins, anti-pseudomonal cephalosporins, quinolones, aminoglycosides, monobactams, carbapenems, and polymyxins. And if it's an Acinetobacter, then there should be a drug resistance to tetracyclines, sulbactam, and tigecycline. And if the bug is resistant to all the 7 classes, then we term it as a pan drug resistant bug. The mechanisms, there are major mechanisms include the enzyme production, that is enzymes that can inactivate the carbapenems, efflux pumps that can pump out the carbapenems from the bacterial cytoplasm, and mutations in the cell wall porins which prevent entry of the drug inside the bacterial cell. But more than one mechanism can operate simultaneously. The hydrolysing enzymes is the most important mechanism because that is very prevalent, as well as it confers very high degree of resistance. So that may be clinically very, very relevant. And in India, the carbapenemase producing enzymes are the carbapenemase hydrolyzing enzymes are the metallobeta-lactamases and the OXAs. And in India, the NDM and the OXA48 are endemic, and the KPCs, the Klebsiella pneumonia carbapenemase is sporadic, whereas in US and all, the KPCs is the one that really predominates. Now, detection, usually the detection starts with a simple laboratory test of culture and sensitivity testing with the MIC determination. But if resistance is not due to carbapenemase production, the MIC can still be in the susceptibility range. So that is one caveat that we need to remember. But certain susceptibility patterns raise some suspicion, including the carbapenem resistance with aztreonam sensitivity often indicates the presence of metallobeta-lactamases. Practically, what we do is we start off with the conventional testing and breakpoint determination. And if the bug has an overt resistance or a high MICs, then we consider resistance and future further tests like the phenotypic tests we perform. And the multiplex PCR arrays that have come help in molecular identification, and they give results very fast along with some of the resistance mechanisms. So these are some of the tests. I'm not going to these things because these are basically the perspective of a laboratory physician or a microbiologist. But the antimicrobial susceptibility test is the good old one, but it has poor specificity and sensitivity, and it has a long turnaround time, whereas many of the newer tests have a much lesser turnaround time. Multiplex PCR, the film array pneumonia plus panel has attracted a lot of attention in the last few years or decades. And we have the film array pneumonia plus panel, which actually detects almost 34 pathogens, 15 bacteria and 3 atypical bacteria, 9 viruses, and 7 antimicrobial resistance genes are detected simultaneously. And if you have an in-house testing facility, the turnaround time would be hardly 2 hours. And the advantages are that very sensitive in detecting, it can detect multiple pathogens simultaneously. The turnaround time is very low, and it can actually detect some of the resistant genes also, but it cannot distinguish between colonizer and real pathogen. So that's something which needs a clinical correlation. And on many occasions, when the conventional culture is negative, the pneumonia panel actually detects the pathogen even after initiation of antimicrobials. And but there are, as I said previously, in this one there are some common bacteria that are missed, like if I'm not mistaken, Citrobacter is one thing that can actually be missed. Morganella, Stenotrophomonas, etc. are not a part of the pneumonia plus panel. So these are some of the bugs that require a conventional culture for diagnosis. So once we detect resistance, what are the available agents and strategies for carbapenem-resistant Enterobacteriaceae? The available agents include the time-honored ones like cholesterol, tigecycline, phosphomycin, minocycline, some of the aminoglycosides, etc. We have the new beta-lactamase inhibitor combinations like the ceftazidime avibactam that's available in India. Some other combinations that have been available across the world include the meropenem vaborbactam, imipenem rilabactam, etc. And of course, some of the standalone agents like cefiderocol, plasmomycin, irabicycline, etc. In addition to this, the extended or continuous infusion of carbapenems is also useful in selected situations, as I will come to later in my slides. The activity of the newer agents, if we see, The ceftazidime avibactam is something that is available in India, which actually is a very good agent for ESBL, AMC, and KPC producing bugs. But its efficacy against metallo-beta-lactamase by itself is not good. Of course, you can combine it with aztreonam in such cases, but as a standalone agent, it's not a very good option for metallo-beta-lactamases. And it's not a very good choice for Acinetobacter baumannii. It's not active against Acinetobacter baumannii at all. And some of the carbapenem resistant Pseudomonas aeruginosa may not be a good target for ceftazidime avibactam. So these caveats are there for this particular agent. Whereas if we see the metallo-beta-lactamases, which are the most important mechanisms of resistance in our part of the world, practically what we can do is we can do a combination of ceftazidime avibactam with an aztreonam. Otherwise, we can sometimes get around with the time-honored agents like polymyxin and all those things. But otherwise, there are very few options. The cefiderocol is a very good option. Plasmamycin and irabacycline might act. A few words on the individual agents. Colistin is a prodrug. We need a loading dose. It has a lot of nephro and neurotoxicity and rapid emergence of resistance. So, and a huge loading dose of 9 million units and 4.5 million units BD is the recommended dose. And there are head-to-head trials of ceftazidime avibactam versus colistin in carbapenem-resistant Enterobacteriaceae, which says that ceftazidime avibactam gives better results. So, whenever possible, colistin moves out of the equation when the bug is actually sensitive and effective with ceftazidime avibactam. The advantage of polymyxin is that it's an active molecule, so there is no need for a loading dose, and the clearance is non-renal, so the dosage modification may be less and the less nephrotoxic. Phosphomycin is very effective for E. coli, but develops resistance very fast, usually used as a combination therapy, especially for urinary tract infections. Can cause actually sodium overload and hypokalemia. Trigicycline, the main problem with trigicycline is the fact that it is the Pseudomonas is inherently resistant to trigicycline, but otherwise it's a very good agent for skin and subcutaneous tissue infections and intra-abdominal infections. The concentration is pretty low in blood and lungs, so it's not a very good agent for sepsis and ventilator-associated pneumonia. The usual doses 100 milligram stat and 50 milligram BD. Supratherapeutic doses have been used in some cases. Minocycline has good activity against carbapenem-resistant Acinetobacter baumannii, usually used as a combination therapy. And it has also the advantage that an oral formulation is available with very good bioavailability. So with this, we come to the ITSA 2021 guidelines regarding the choice of optimal agent or strategy. So it depends upon the genus, whether it is an Enterobacteriaceae or whether it is a Acinetobacter or whether it is a Pseudomonas. And again, whether it's an ertapenem monoresistance or ertapenem meropenem multi-resistance, the site and severity of infections, especially UTI versus non-UTI, the mechanism of resistance, carbapenemase versus non-carbapenemase production, and the actual MICs encountered. So in non-UTI cases, if the bug is resistant to ertapenem but susceptible to meropenem, then again you have a role for an extended infusion of meropenem. If the second option would be a ceftazidime avibactam. Whereas if the bug is resistant to ertapenem and meropenem both, and the carbapenem testing results are not available or negative, then probably a ceftazidime avibactam, meropenem vaborbactam, or an imipenem cilastatin rilabactam combination would be good. The alternatives would be cefiderocol, and if it is an intra-abdominal infection, the glycyl cyclines, trigicycline and irabacycline. If we identify KPC, then ceftazidime avibactam is a very good option. Whereas if metallo-beta-lactamase is detected, then ceftazidime avibactam with aztreonam or cefiderocol becomes the best option. A few selected evidences with each of them. Ceftazidime avibactam for MBLs. This was a very good study of prospective observational study of around 102 MBL producing isolates in critical care. And it was seen that 30-day mortality of 44% with ceftazidime, with the alternate best treatment versus 19% with ceftazidime avibactam. And this difference is pretty huge, so that this becomes the preferred choice. Many other things, the meropenem avibactam has been evaluated in the Tango 1 and Tango 2 studies. Again, superiority has been proved. The 28-day all-cause mortality has been better in the meropenem avibactam group. Other newer antibiotics, the imipenem cilastatin rilabactam has been studied in a couple of trials. Again, it's a RESTORE-IMI-1 and RESTORE-IMI-1-2, RESTORE-IMI-2 trials. This was again imipenem tolabactam with some of the competing agents, and it was seen that similar very good results were seen, and many of these patients in this RESTORE-IMI study had a clinical profile very similar to our VAP profile, so it's very relevant for Indian population also. Spidaracol has been studied in the credible CR trial, again a multi-center open randomized control trial. It was seen that multiple etiologies were looked at and clinical outcomes were similar as compared with the best of care. Plasmomycin is another new agent. This also is very good, and there is a much lesser renal toxicity with plasmomycin as compared to colistin. Now, in addition to all these agents, other strategy that we can use is to optimize the pharmacokinetic and pharmacodynamic parameters. So, at least in the case of beta-lactam antibiotics, as opposed to a bulk infrequent dose, a frequent dosing, either as an extended infusion or even as a continuous infusion, will be a much better strategy, especially in those cases with a high MIC and those cases with an ertapenem monoresistance with sustained meropenem sensitivity. So there are multiple meta-analysis which says that the continuous infusion strategy of carbapenem gives better clinical results. And the future would be the potential agents include newer beta-lactamase inhibitors or carbapenem beta-lactamase inhibitors, bacteriophages, and something known as the odeilorhabdins, which are actually peptide antibiotics targeting unique ribosomal subunits. Some of the agents under development include cefepime cidibactam, meropenem nacubactam, and cefepime enmetazobactam. Finally, although we employ all these techniques, sometimes we see in vitro versus in vivo disparities because we see that despite the fact that we give the proper sensitive drug, the clinical response does not occur. So the host response has to be good. We have to initiate the drug early enough. There may be in vitro, in vivo disparities in testing. There may be persistence of the source of sepsis, or there may be a polymicrobial infection or a second wave of infection or a fungal sepsis, etc., etc. The other thing is also correct. We see a patient who otherwise fits in with the sepsis syndrome, but he has no clinical isolates. So this may be due to multiple things like the sepsis mimics. It can be a thromboembolism or a drug toxicity, etc. It can be a slowly resolving multi-organ failure, or it can be due to a technical deficiencies in the specimen processing, like delay in sampling or delay in transporting, or not the proper storage media, etc. Or identification of the incorrect source of specimen, sample collection after initiation of antimicrobials, etc. So summarily, if I put all those things into one slide, so multi and pan drug resistant gram-negative bacteriaceae is a very, very serious and growing problem. We should suspect it based on our locality, the antimicrobial sensitivity pattern of our locality. Suspect based on antimicrobial susceptibility tests and identify the genetic mechanism by further tests. Therapeutic options include a lot of things, and again depend upon the site of infection, the mechanism of resistance, and the MICs. Lots of upcoming options, and the newer ones probably need better evidence before we really start implementing that in our day-to-day practice. Thank you.
Thank you, Rajesh.
I think if any queries are there, I think probably we can address it in the later stage. I think we are ahead of schedule, so probably we'll move to the next session. I think Paramesh is also around. Yes, Paramesh is here. Thomas is here. So I request Dr. Paramesh, Senior Consultant and Head of Pulmonary Medicine at Lizzie Hospital, to introduce Dr. Thomas as well as the topic, and then hand over to Thomas.
Good evening, all. Hope I am audible to you.
Yes, you're audible.
Yeah, thank you. At this outset, I would like to thank the Kochi Safe Skill organizers, Dr. Rajesh, Srivalsan, and Unni, for making this event happen and inviting me to this program. It's a very innovative program as far as the juniors as well as young pulmonologists are concerned, because most of the topics that we select are pretty much good and relevant for a practicing physician as well. So coming to today's topic, this is one of the topics that is actually close to me. Actually, we did many programs on this particular topic, educating the younger pulmonologists and all. So this is regarding bronchiectasis, non-cystic fibrosis bronchiectasis, and the usage of medicines, especially inhaled antibiotics for eradication of Pseudomonas aeruginosa infections in the lungs in patients with bronchiectasis. As you know, bronchiectasis is in the last week only, Dr. Praveen has already spoken about the bronchiectasis and how we are missing the bronchiectasis, and the timeline of management of bronchiectasis, how we are going to miss if not properly addressed in time. So this is the topic per se. And to talk about this, and for the topic that has been selected is from the CHEST 2023. To talk about this, I got my colleague himself, who is Dr. Thomas Kurian. He's a consultant pulmonologist at Lisi Hospital itself, and he has done his MBBS from Jubilee Mission Hospital, Trichure, MD in Pulmonary Medicine from SMS Hospital, Medical College, Jaipur, and he has got various degrees like IDCCM, EDIC, and MRCP Respiratory, and European Diploma in Adult Respiratory Care. And over to you, Thomas, for discussing this particular topic. Thank you.
Yeah, thank you, Parameswar. I hope the screen is visible.
Yes, sir, it's visible, sir.
Okay, thank you. So today, I thank you so much for the kind words, Parameswar. It's an honor to be actually presenting in front of two of my mentors, Parameswar and Srivalsan sir. And thank you so much, Rajesh sir. I think Rajesh sir only selected this topic. And also thank you so much to the Cochin Safe Skills Academy, Dr. Unni, Dr. Srivalsan also, for inviting me for this lecture. The topic given to me is a niche topic. It's a very specific subset of patients who have bronchiectasis and chronic pseudomonal infection. Not the case which, not the patients who you might see on a daily basis at least. But these are patients who would highly be benefited by your intervention. Bronchiectasis by definition is a irreversible disease, and that is why a lot has not been talked about or researched about bronchiectasis. You can see the vicious cycle described first by Cole, in which the first hit is an inflammation, followed by you can see that there is a permanent loss of airway dilatation and loss of cilia, which causes mucus accumulation, of which there are bacterial colonization in that mucus and infection. And this is a vicious cycle of bronchiectasis, which is described long back. Now, in this bronchiectasis, you can see that there is one organism which is far more superior to every other organism which we encounter. And that is Pseudomonas aeruginosa. Why? Because it causes the most severe disease. It causes the greatest impairment in lung function. It causes increased airway inflammation. There are more frequent exacerbation. It has a worse quality of life. And there is a nearly 7-fold increase in risk of hospitalization and a 3-fold increase in mortality. And you can see that it is all with bronchiectasis, with Pseudomonas, and without Pseudomonas. Why is this so important? To put things into perspective, we can see that as pulmonologists, many of us would be seeing the most severe cases of asthma, the most severe cases of COPD. And a St. George's Respiratory Questionnaire, which is a quality of life questionnaire, you can see that it will be around 40 to 50 in severe asthma and severe COPD. In this particular patient with a bronchiectasis with Pseudomonas, you can see that the quality of life is much worse than the average severe patient which we otherwise see in the OPD. What is chronic Pseudomonas aeruginosa infection? The first growth of Pseudomonas aeruginosa, you can probably consider eradication treatment, and the treatment is very specified also. You can have 2 weeks of IV or oral antibiotics followed by at least a 3-month course of inhaled antibiotics. Now, chronic infection has been defined variantly in different studies, but an accepted definition would be positive cultures on 2 or more occasions, at least 3 months apart, over 1 year in stable state. And in these patients, chronic maintenance antibiotics may be considered. So you can see that this would be the Pseudomonas aeruginosa. And in the initial phases, it is a motile one with a flagella. You can see that it colonizes the sputum and early infection is brought about. What happens is if the Pseudomonas is not fully eradicated, some of them will persist. These are the persister cells, and some of them will lose the flagella and become the non-motile form. See, the non-motile form is the problematic one. It forms an alginate covered mucopolysaccharide around itself. And this biofilm is resistant to most antibiotics. And this is why Pseudomonas is treated differently with a 14-day course of antibiotics. Also, in most of the severity scores, you can see that this is the FACET score. You can see that chronic colonization with Pseudomonas aeruginosa itself has 1 score. So I hope we have taken home the point that Pseudomonas in itself has a very poor prognosis in bronchiectasis. Now a note about inhaled antibiotics, which have been specifically brought about for this gram-negative infections in bronchiectasis. So most of the trials in bronchiectasis have actually replicated what has been proven in cystic fibrosis. In cystic fibrosis, the role of inhaled antibiotics is well established, and also there is a very good improvement in the quality of life. There is a reduction in frequency of exacerbation. But these same studies have not been replicated in non-cystic fibrosis bronchiectasis. Which are the antibiotics which have been used for this purpose? The first is aminoglycosides and colistin, cephalosporins, fluoroquinolones, and estrionam. You can probably take off estrionam because there have been a lot of trials with very poor results and an increased risk of adverse effects with estrionam, and that is sparingly being used. One feature of this inhaled antibiotics which are being used for bronchiectasis is that it will be mostly concentration dependent, not time dependent, so that there is a high dose of the antibiotic in the area of interest. Obviously, this will be having lesser systemic toxicity. Some prerequisites with a nebulized antibiotic is that it should be sterile, preservative-free, and non-pyrogenic. One advantage of tobramycin in this regard is that it is an aminoglycoside. It binds to the 30th subunit, and it is a protein synthesis inhibitor. This is one antibiotic, inhaled antibiotic, which has been specifically made for the nebulized form. Unlike the colistin, if you would have seen that the colistin, mostly it is the IV preparation itself which is being marketed as the nebulized form. One other peculiar thing about these inhaled antibiotic use in bronchiectasis is that there is an on-off cycle. It will be 14 days of nebulized antibiotics followed by 14 days of this nebulized antibiotics. And some trials have 28 days on and 28 days off cycle. This is basically more of a theoretical point of view more than a practical or a research-oriented point of view. But the basic premise is that it would probably reduce the cumulative toxicity, and it also reduces the risk of bacterial resistance. And mainly it is theory-based. One final thing is about the quality of life. So the quality of life, unlike in other respiratory diseases, quality of life in bronchiectasis is so much different because of the chronic sputum production. And there is a specific score, which is the quality of life bronchiectasis respiratory symptoms score, which is specifically for bronchiectasis. It is mostly used only in research settings, but it has many domains, of which respiratory symptoms, physical functioning, vitality, role functioning, health perceptions, emotional functioning, social functioning, and treatment burden. These are taken into account. I don't think you need to look too much into detail. Mostly it is a research tool. Also, another quality of life tool specific for bronchiectasis is the bronchiectasis health questionnaire. So both of these also I just wanted to introduce. So with this premise, we know about Pseudomonas aeruginosa, how it becomes from the non-mucoid to the mucoid form, which are some of the nebulized antibiotics which is used. And we'll come to this trial, which is the largest trial on tobramycin, which has been undertaken, and it was published in January 2023 in Chest. It is a double-blind, randomized, placebo-controlled phase 3 trial of tobramycin inhalational solution in adults with bronchiectasis with Pseudomonas aeruginosa infection. So let us go straight into the trial. The objective of this trial was to assess the efficacy and safety of tobramycin inhalational solution in patients with bronchiectasis. And the patients at baseline had standard care of chest physiotherapy and mucolytic therapy. What were the included patients in this study were patients aged 18 to 75 years with symptomatic bronchiectasis, which was confirmed by an HRCT imaging, and the patients had to be clinically stable for 4 weeks with positive sputum culture, of course, for Pseudomonas aeruginosa, at least at 2 consecutive screening visits and at least 1 exacerbation within the previous 2 years. Here you can see that the study population has less frequent exacerbators as the inclusion criteria in this. Patients who were excluded were patients with allergy to tobramycin inhalational solution, patients with other concomitant chronic respiratory diseases as the cause of bronchiectasis. For example, a patient with ABPA with bronchiectasis or an inflammatory bowel disease with a bronchiectasis. These patients were excluded almost always. It were idiopathic patients of bronchiectasis which were included in this study. Why? Because there is a lot of confounding factors otherwise of treatment which can happen otherwise. Patients with major hepatic or renal dysfunction were excluded. Pregnancy or lactation was also excluded from the study. The patients were randomized in a 1:1 ratio. It was stratified by center. It was done in multiple centers in China. And the blinding was a double-blind study. So the patients or the investigators did not know which drug they were receiving. Although a patient or a researcher, if they had tasted the drug, they probably would have made out the difference, but it was blinded almost. And the placebo looked at least indistinguishable from the tobramycin inhalational solution. The placebo was actually normal saline. There again, there is some problem because normal saline itself for nebulization would help as a mucolytic, but that is generally how it is done in all trials. And patients received 300 milligram of twice daily tobramycin or normal saline 5 ml twice daily. The standard care was chest physiotherapy of 5 minutes once daily, and mucolytic treatment was ambroxol or N-acetylcysteine. The treatment cycles were 28 days on, followed by 28 days off treatment. We looked at the rationale for that, and follow-up assessments were done every 4 weeks after randomization. The adherence was assessed through diary records. What were the endpoints they looked? Endpoints were the change in the Pseudomonas aeruginosa density in sputum and the quality of life score, which we previously discussed. These were the co-primary endpoints they wanted. And there were other secondary endpoints like the time to first exacerbation, frequency of exacerbation, the BHQ score, the volume of sputum, the purulence of sputum. And the analysis was done as modified intention to treat population in patients who at least received 1 dose of tobramycin. They were included in the modified intention to treat population. They planned to recruit around 350 patients, and if the superiority would be there if both co-primary endpoints we saw previously reached statistical significance. So you can see that out of the 357 who were randomly assigned, 177 in the tobramycin and the placebo group, ultimately, some patients had protocol violation and adverse events. Some patients discontinued treatment. In patients who had efficacy data, around 167 were included in the modified intention to treat analysis in the tobramycin and 172 in the placebo. You can see that at the baseline, both the tobramycin and the placebo group were well matched. The age was around 50 to 53 years. Female patients were around 60% of the patients. What you can see were most of the bronchiectasis severity was severe. Around 76% had severe bronchiectasis at baseline. The etiology we already saw was mainly idiopathic patients. Very few patients were post-tubercular. And medications at baseline also, inhaled corticosteroids were used in a very small subset of patients only. This is in stark contrast to the EMBARK study, of which in population had a higher chance of having inhaled corticosteroids in their regular prescriptions. Also, you can see that macrolide therapy was also used in 10% of patients. The chronic macrolide therapy was also. And we can see that these were the two primary endpoints. One was the sputum density of Pseudomonas. You can see that during the on period, there was a significant reduction. And during the off period, there was a slight increase. Then again, a significant reduction during the off period. So this reached statistical significance. Also, the quality of life from the placebo group, which is the red, and the tobramycin group, you can see that there is a significant improvement in the quality of life in these patients. Also, the secondary outcome measures of the sputum volume, they collected sputum in a container and they assessed visually about the purulence also. And these also were significantly improved in the tobramycin group in comparison with the placebo group. The change in FEV1 was not very consistent across the study, and there was a reduction actually in FEV1 during the on period of the study in tobramycin group. So that means that some patients with bronchiectasis had a hyper-responsiveness to tobramycin. And this is the summary of all the primary and secondary endpoints. You can see that the primary endpoints both had a significance. Also, the volume purulence was also improved. At day 57 also, the volume and purulence improved. At day 85 also, there was a reduction in Pseudomonas density. You can see that what was not really improved was the BHQ score, the quality of life score at day 85 was not very significant. You can see that both, also what was not significant was the change in the exacerbation frequency, which was similar in the tobramycin group and the placebo group. This, I think we can partly think that that was expected because of the short duration of the study. It was just 16 weeks in an infrequent exacerbator. So the exacerbation frequency, there was not much of a difference between the two study groups. One other finding was the tobramycin group showed an increase in MIC compared to baseline at 29 days, although by the end of the study, this was not significant. And also there were some strains of Pseudomonas aeruginosa which were tobramycin resistant at the end of the study, but these did not cause any treatment failure. The safety profile also, this was found to be relatively same across the treatment and the placebo group. There was a high incidence of adverse events, but there were mostly mild to moderate only. You can see that a lot of patients had hemoptysis, chest discomfort, and upper respiratory tract infection. Severe adverse events were very sparingly reported, and one patient with death in tobramycin, but that was ultimately not related to the study drug. Also, which were the patients who had the greatest change was in male patients who did not receive macrolides or inhaled corticosteroids. So I hope you got the gist of the study. What were the limitations in the study? One was that this was a relatively younger group. The age group was around 50. Mainly Chinese ethnicity patients were only enrolled. The on-off regime was used. So how would it compare to a continuous regime? We still do not know. It was a relatively short duration of only 2 cycles done. The frequency of exacerbations was not made as a primary endpoint. And this COVID-19 was written as a limitation by the study group itself, because they did it during the COVID-19 pandemic also, and a lot of sputum collection was a bit difficult for them. And they looked at only one organism of Pseudomonas aeruginosa alone. But ultimately, the results were that there was a good reduction in density in the quality of life, and there was a reduction in sputum volume, sputum purulence, and more patients became culture negative at day 29. So this was the summary slide by the chest itself. And you can see that the sputum purulence and the quality of life was significantly improved. So finally, prior to me signing off, let us look at a few other trials which were done other than this. And these were the Respire 1 and 2, which looked at ciprofloxacin, Orbit 3 and 4, which again looked at liposomal ciprofloxacin. The iBest trial looked at tobramycin inhalational powder by a dry powder inhaler. The PROMISE study was based on colistin. So the Respire 1 and 2 were done, and it was published in ERJ in 2018, and it was done for ciprofloxacin, with ciprofloxacin in the same subset of patients, but not limited to Pseudomonas. They looked at other pathogens also. They had a list of 7 pathogens, and they looked at patients. It was a paired RCT. One was in Europe, North America, and the Respire 2 focused on Asia. So what is important is that paired RCTs are required prior to FDA approval of these drugs for this particular indication. So that is why this was done as a paired trial. And what they found was there was contrasting results across the 2 studies. The inclusion, exclusion, everything was similar. Just the location, geographic location was different. The Respire 1 found that there was an improvement, but there was Respire 2 found that there was no statistically significant improvement in the time to first exacerbation. Then again, another study in Lancet. This was with a liposomal ciprofloxacin inhaled form itself. Here also it was a paired trial, which looked similarly at Pseudomonas aeruginosa though. And here also, just similar to the previous one, we found that one trial, the Orbit 4, found that there was an improvement, whereas the Orbit 3 failed to achieve the same primary endpoint. So let us look at another trial, which was the tobramycin, which was done as a dry powder inhaler. This was a well-conducted study, and but the problem was that it was terminated prematurely because the study sponsor was acquired by another company, and they had to stop the study in between. But you can see that across all doses, at higher doses of tobramycin, there was a significant improvement in the Pseudomonas aeruginosa sputum density. And finally, the last trial was with colistin, which was a randomized controlled trial. This showed significant improvement in the annual exacerbation, prolonged the time to first exacerbation, quality of life improved, and the paired RCT, the PROMISE 2, is currently underway, and the results are going to be out in the near future. So before I sign off, this is the European Respiratory Journal on how you manage frequent exacerbators of bronchiectasis. You first optimize airway clearance, see whether the patient has Pseudomonas aeruginosa infection. If the patient has Pseudomonas aeruginosa infection, you can consider long-term inhaled antibiotic. The 2 antibiotics that they recommend are colistin and gentamicin actually. If the patient does not have Pseudomonas aeruginosa, you could consider long-term macrolide therapy with azithromycin. A dose of around 250 milligram to 500 milligram thrice weekly is recommended. If the patient after 6 months of this treatment has no improvement, you could even switch over. So even if the patient has been on inhaled antibiotic, you can switch over to macrolides and vice versa. And still, if the patient has inadequate response, you could consider both of them together. Finally, what is our practice? So we at Lisi Hospital, we use the jet nebulizer. That is debatable how well the nebulization would occur with jet nebulization, because consistently it will be a lesser amount of drug which will be delivered to the patient. Across studies, it is around 15 to 20% of the drug which is delivered with jet nebulizer. In all of these trials, you can see that vibrating mesh nebulizer is the preferred one because of the cost concerns, because the patient itself is you're going for tobramycin, you'll be spending around 20 to 25,000 for the tobramycin nebulization for a month. So that is what we use. We prime the patient with an inhaled bronchodilator with a levosalbutamol plus ipratropium. Follow that up with chest physiotherapy and give the mucolytic in that duration, and then give nebulized tobramycin for around 15 minutes. It takes at least 15 minutes for it to completely be delivered by a jet nebulizer. Who are the patient groups? It will be similar to the ERJ, frequent exacerbators of 3 at least for the past 1 month, for past 1 year. We give it at least for 6 months, and the duration is 28 days on-off cycle. So in summary, I would like to tell that this is not the holy grail in treatment for chronic Pseudomonas aeruginosa infection, but this definitely improves the quality of life. It also reduces the Pseudomonas aeruginosa density. And in this niche patients, you could definitely try that out. Thank you so much for your patient listening. Over to the chairs.
Yeah, thank you, Dr. Thomas. That was well elaborately mentioned. You have mentioned all the aspects of management of Pseudomonas infection in bronchiectasis. Yeah, it is not a very easy job to treat Pseudomonas infection in any structural lung disease, be it ILD, COPD, or for that matter, bronchiectasis. And by the time you treat one bug, it is going to we are going to have troubles with other bugs and the MDROs happening. So the journal topic, their study, though it is conducted for a very short period of time, it was well blinded study, and we could actually compare the results also. Now we have got a question from the audience regarding, it's not directly regarding this one, but a question from Jacob. I presume that it is Jacob from the critical care background. If you are giving colistin for nebulization, we combine it with IV colistin. If we use other drugs like tobramycin for inhalation, we don't advocate IV drugs. Any idea why this difference in administration? Thomas, would you like to take up, or?
I think, yeah, the indication in this regard is just for reduction of the Pseudomonas aeruginosa density. It is not, we are not treating the Pseudomonas at all. For an acute event, what we do is combine this nebulized tobramycin with either, actually according to guidelines, it is ciprofloxacin 750 milligram tablet is enough for twice daily for 14 days, and follow that up with 3 months of tobramycin. That is for eradication of Pseudomonas. In a VAP treatment, of course, it is IV colistin. You should never be giving colistin alone. The purpose of using the nebulized tobramycin in this is different from a critical care setting. So here we can give it alone because we are giving it not for treating an acute infection. Even if this patient has a Pseudomonas aeruginosa infection and patient has an acute infection, patient is in the ICU, we always have to combine beta-lactam, beta-lactamase inhibitor, or a ciprofloxacin, or even combine it with a levofloxacin. So there is a three-pronged approach actually. There is not much of a difference between either, but for eradication, even in the acute form, acute time, you should follow it up with 3 months of nebulized antibiotics.
Yes,
so
yeah.
I hope that is.
Yeah, to summarize, the context is different for both these antibiotics in this regard, because one is used in an ICU setting for an acutely ill patient, and this one is being discussed for the management eradication protocol for the bugs on an OPD basis or a home-based basis. One thing I would like to add, as far as the practical point is concerned, we also effectively use the breath-actuated devices, so that the nebulized form of antibiotics are not lost, and to ensure that it is properly inhaled into the by the patient, rather than just switching on the device and the drug goes out and the MICs goes down. So to ensure a better absorption, we can actually combine it with breath actuated devices like Lupinab Ultra and all, so that the patient gets the adequate concentration of drug into the lower airways, and probably will be more effective. Or for all practical purposes, I have found it much effective as far as the nebulized therapy for antibiotics are concerned. Rest of the things, I think Thomas has already covered elaborately. Excellent talk. Other questions from the floor? If not, we will close the session and then hand over to the next chairperson. Thank you. Thank you, Dr. Thomas. Next is by Dr. Praveen.
Yeah.
Praveen, hand over to you.
Yeah.
Thank you.
Yeah. So a very warm good evening to one and all. Thank you, Cochin Safe Skills, for giving me the opportunity for me to be here. So the next topic is an extremely important topic, in the sense that the antifungal, the fungal infections are on rise, and that's something that we have seen during this COVID pandemic, as well as now in this flu season. We do see a lot of patients who are coming with fungal infections. So what are the current, the newer options that is currently available in this setting, and the more importantly, the antifungal, the resistance is also on rise. So in that aspect, the antifungal stewardship is also very important. And there are newer, the modes of treatment, the modalities of treatment is also coming up. So to talk on this subject, we have an excellent speaker, Dr. Sajida, who is an assistant professor in Cochin Medical College. So without much time, I'll hand over the mic to Dr. Sajida. Over to you, ma'am.
A warm good evening to all of the participants and the delegates. At the outset, thank you, Dr. Praveen, for the excellent introduction and the nice words spoken. And thank you, Cochin Safe Skills, for this opportunity to present a very important topic, I consider, in this present scenario of actually the fungal infections came into foray during our COVID infection, and they actually got their due recognition during COVID, during the post-COVID era. And in this era of immunosuppression, where we use immunosuppressants for the rheumatology. Hello.
Sorry for the interruption, but the full screen is not visible, ma'am.
Actually, I have I have made it full screen. How can I change it?
You need to share your entire screen instead of setting a particular tab. Let me guide you. Click on the share screen.
Okay. Sorry for the interruption. I'll try.
Now, once click on the share screen, you can see the very first option under the basic options, which is screen. Select it, and then push the share button. Then just click the share button. Then your entire screen will be visible.
Okay. Actually, I've opened the slide and made it slideshow. Okay.
Now you can come on the Zoom platform.
Yeah.
And click on share screen. Now, can you see the screen option, the very first one, ma'am?
Yeah, I've seen the share screen option.
Just click on that and the one window will open. In that window, you will see the screen option, the very first one. Is it there, ma'am?
I can only see the share screen option.
Ma'am, have you clicked on share screen?
Yes.
And now what you can see, can you please tell me?
I can actually okay. I can see open windows of the Zoom meeting and also the PowerPoint slideshow, which I tried to open.
Okay, any other options like the screen, whiteboard, anything like that?
No, just that the basic option.
Okay, then just select the slideshow one, slideshow mode option. Let us check. I think you have joined from a web mode. That is why. Select the one which you have done in the slideshow. Select that particular
Slideshow.
tab.
Okay.
Yeah, and now still the slideshow is not visible, ma'am.
Okay, I'll make it once more. Yeah, I've done the slideshow.
No, it's not visible, ma'am.
Okay, I'll stop sharing and do it once more.
There should be a full screen option. Entire screen or full screen or entire window.
Optimize for this video clip.
No, 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 ma'am. Optimize. It is not there. Under the basic options, there are so many options, and the very first one is the screen.
Yes.
Just click on that screen.
Yes.
And now click on share button. Click on share.
Okay. Now I have clicked on the share button. Yes.
The screen should be visible, but it is not visible, ma'am. Your screen is not visible. Anything is not shared.
What about this?
Okay. Now it is there. Perfect. There you go. Could you try to move once, ma'am? Could you try to just move the slides?
Yeah.
Just try to move.
Oh, it's not moving.
Click on it. Yeah, moving. Perfect.
Okay, thank
Perfect.
you.
Thank you, ma'am.
Sorry for the interruption. Thank you, Cochin Safe Skills, for this wonderful opportunity to present this very important session, I think. What is new in fungal infections? I'll be just rushing through some new new articles which have appeared on the new journals regarding the fungal infections. Actually, it covers two paper review articles actually, and two new original articles on the newer antifungals. So this is one paper from the intensive care medicine, which was published in March 2023. It's a review article actually as to what all is happening in the diagnosis and treatment of fungal infections. So actually it covers all fungal infections rather than pulmonary fungal infections alone in the critical care. And the most salient features discussed are regarding biomarkers. So as we all know, the beta-D-glucan is the most important biomarker used for invasive candidiasis. And it is considered superior to all the bedside clinical prediction models and colonization indices in settings with both high test probability and low test probability, but with very high sensitivity, and a very high negative predictive value. But the specificity is sort of low because of some false positive results, especially in the low pretest probability settings, because of it may be because of fungal colonizations due to albumin and immunoglobulin administrations, which may be coexisting in the ICU care settings due to hemodialysis, etc. So a multicenter randomized control trial, which compared to two positive beta-D-glycan strategy with the culture-based targeted therapy, found that it was actually the primary endpoint was survival benefit, and it was found that in using it in early invasive candidiasis diagnosis and treatment, there was no survival benefit in using this as the primary modality. And it was found that in biomarker guided arm, the antifungal therapy was initiated in almost half of the patients, despite the low rate of actual invasive candidiasis. But this was actually done in all patients, and so this was probably including the low risk of invasive candidiasis patients, and the result came as beta-D-glucan cannot be recommended, but only in the patients with the low pretest probability. In high pretest probability, probably that is beta-D-glucan is still the most recommended biomarker, because actually seen in 2 randomized controlled trials, which supported this use, either using beta-D-glucan alone or by using it with Mannan antigen or anti-Mannan antibody as a rule-out diagnostic tool. It was found that in high pretest probability test settings for invasive candidiasis, actually the use of biomarker is actually beneficial. So beta-D-glucan is still the most important biomarker we have in candidiasis. What about galactomannan, which we use frequently in pulmonary ICUs also, because that is the most important pulmonary fungal infections we encounter. That is the hallmark biomarker tester we know as for the diagnosis of invasive pulmonary aspergillosis in critically ill patients. And the cell wall component may be detected in both serum and BAL samples, as we all know. And the latter sampling shows higher sensitivity and specificity with a cutoff of more than 1, which is actually higher than the serum one. But actually the new guidelines also propose that in definite critically ill patients with high pretest probability of aspergillosis, the serum marker can also be taken as a high cut indicator. So, as we all know, the risk factors for IP include immunosuppression, chronic obstructive pulmonary disease, and cirrhosis. And so, in such assays and in such cases, in critically ill patients, we can use galactomannan as a very good marker. So what about the turnaround time for, as we all know, galactomannan is very high, and sometimes the aspergillus lateral flow assays, which is a point of care indicator, has come out as the point of care tool for early diagnosis of invasive pulmonary aspergillosis, but it is actually limited by the low specificity, though it has got a very high sensitivity. What about de-escalation of antifungal treatment? Once we start treatment, the next point is regarding the de-escalation of antifungal treatment. So switch from the initial antifungals to triazoles, or discontinuation of the initial antifungal treatment within 5 days. This is definition of de-escalation. And in a landmark multicenter observational study, they reported that antifungal de-escalation, the de-escalation was actually studied only in invasive candidiasis. The de-escalation actually showed a reduced duration of antifungal treatment did not have any negative impact as reported to the outcome as the survival benefit or mortality. No actually negative impact on the mortality outcomes or the survival outcomes. And so early de-escalation is actually recommended in invasive candidiasis. And as we expected, the invasive mechanical ventilation was found to be associated with lower rate of de-escalation. So total duration of the antifungal treatment was definitely short in patients whom de-escalation was implemented, and there was no significant differences found in the duration of invasive mechanical ventilation, the length of ICU stay, mortality, or 1-year mortality. So early de-escalation is recommended. What about therapeutic drug monitoring? As we all know, the therapeutic drug monitoring, especially in the case of triazoles, where you measure the trough levels, is very important in invasive pulmonary aspergillosis and the invasive candidemias. And the TDM-guided dosing is found to have been clinically beneficial for triazoles, that is voriconazole, and is recommended routinely in critical ill patients now. So another new diagnostic tool, that is Candida magnetic resonance imaging, has been recently tested in patients with suspected Candidemia bloodstream infection. But actually, though they are faster than the blood cultures, the accuracy is still low because of the low specificity. So combining all in diagnostic arena, we still found that the high rate of invasive fungal infections ICU is still due to the Candida species, mainly due to, especially in catheter-related patients who are on central line, and Aspergillus species contributed about 10%. And early de-escalation is safe, but the study has only been done in invasive candidiasis, not in aspergillosis. And this reduces the spectrum of pathogenic fungi which occurs in critically ill patients. And the still beta-D-glucan can be used for early de-escalation as a prognostic master also, and galactomannan can be used for early diagnosis invasive aspergillosis. And a multimodal approach, actually combining the rapid diagnostic tests which we discussed just now, along with therapeutic drug monitoring and presence of an infectious disease specialist, can definitely give good survival benefits in invasive fungal infections. So that is the final summary of this review article. Now, rushing to a original article which on invasive candidiasis in critically ill patients. So this paper, which came out in Lancet in infectious disease recently, actually that found that actually monitored whether the guideline adherence to the recent ESCM guidelines on invasive candidiasis helped really in the survival of patients who were having invasive candidiasis in the ICU. So ECMM collected data on the epidemiology, risk factors, and treatment and outcome of patients with culture-proven candidemia across Europe to assess how adherence of guideline recommendations is associated with outcomes. And the study was done in 64 countries in 632 patients with candidemia. And overall 90-day mortality was the outcome. And it was the increasing age, the intensive care admission, point increase in the comorbidity indexes, and Candida tropicalis as a causative pathogen were the independent baseline predictors of mortality which were studied. And the interpretation was that although overall mortality in patients in Candida was still high, it indicated that strict adherence to the clinical guideline recommendations, that is, which was actually promoting initial adherence to the echinocandin treatment, along with adherence to the equal Candida scores, will increase survival definitely in invasive candidiasis. Candidemia remains the background of the study. We all know candidemia remains the disease with a very high mortality, and so although across Europe, it was found that in mortality in adults with candidemia remains high at 43%, adherence to clinical guideline recommendations is still low. So it was found, the study was done so as to know whether strict adherence to the Candida guidelines will help in better survival. And more, the guideline recommendations such as performance of ophthalmoscopy or echocardiography in assessment of patients also is whether it is also associated with increased survival, and treatment of echinocandins, whether it is associated with an increased overall survival, and longer duration of hospital stay for completing the parenteral therapy of echinocandins. Does it really contribute to a negative survival effect? And these were the factors which were studied. It was a multicentral observational study, and it was found that the underlying hematological or oncological malignancy, ICU admission, and recent major surgery were the most common risk factors for candidemia. Though the overall mortality was 46%, 37%, which is still high, it is death attributable to candidemia. And the overall mortality but was lower in patients who received initial echinocandin treatment than in those who did not receive such a treatment. And it was also found that the performance of ophthalmoscopy and echocardiography and the treatment for 14 days after the first negative blood culture, all that actually non-performance of this and if the patient was early de-escalated to fluconazole, all that contributed to mortality. And the mortality was less in patients who had strict adherence to guidelines after adjusting for age and the comorbidity also. And for every point decrease in the equal candida score, which detects the adherence to therapy, there was a increase of death by 9% for patients who were on a central catheter, and for 8% for patients without a central venal catheter. And it was also found that if the guideline recommended diagnostic and therapeutic measures were not performed, they definitely had a high mortality. And it was also found that Candida tropica, rare Candida species like Candida keffer, the Candida auris, they were all significant baseline predictors in the univariable models. And it, further, though the initial echinocandin treatment actually led to an increased duration of hospital stay, we can actually look forward to the new antifungal pipelines, like which includes resafangin, which has got an which is an echinocandin with improved penetration of the peritoneal fluid and extended half-life. This will allow a once per week administration as compared to the daily administration of echinocandin, and this might actually decrease the hospital stay also. So that much about the invasive candidiasis guideline. And I'll just skip this slide actually, which contains the newer antifungals, which most of which are not available now in India. So, and we'll go to this article from Lancet Infectious Disease, again containing regarding the resafangin, the newer antifungal agent which is coming on for invasive candidiasis, which and it was a actually randomized controlled trial comparing two arms, giving resafangin in one and caspofungin with a double-blinded. It was a double-blinded trial, that is a RESTORE trial. The results are out now. The evidence before the study was that echinocandins were the first recommended first-line drugs for the treatment of invasive candidemia, and with a good favorable safety profile and functional antifungal activity. But as we know, it actually contributes to an extended hospital stay because of the IV preparation, which has to be given daily. So resafangin, which is a novel echinocandin with a once-week intravenous administration, was studied as two study group. And the results was that overall evidence for resafangin shows a similar clinical safety and efficacy to the inclusion criteria actually included the systemic signs of infection attributable to candidemia and invasive candidiasis with the micrological evidence of candidemia, and patients with deep-seated infections like osteomyelitis, meningitis, arthritis, the chronic disseminated candidiasis, chorioretinitis, and endocarditis. Such deep-seated infection patients were excluded so as not to have a skewed results. And any prior antifungal treatment within 48 hours, they were also excluded, and they were randomized and double-blinded and given those. And it was found that the resafangin arm is non-inferior to caspofungin for the pre-specified primary endpoints of all-cause mortality at 30 days. And early negative blood culture was also obtained in resafangin, though it was a weekly regimen with clearance of fungemia, but it was not found to be statistically significant. So resafangin is a good alternative for invasive candidiasis, which will reduce the hospital stay also, but it has to be yet available in India. So coming to the last journal which appeared in Journal of Fungi in 22, actually, which actually it is a review article which studied the conventional antifungals as unconventional methods by aerosols, irrigants, or cements. So it actually dealt with all fungal infections, and I will point my discussion only to the relevant respiratory part, that is inhaled antifungals like the amphotericin deoxycholate, the liposomal amphotericin, and the amphotericin liposomal complex as endobronchial instillation, as sometimes is done for endobronchial aspergillosis, or percutaneous or intracavitary instillation of this amphotericin for pulmonary aspergilloma, and whether inhalation of amphotericin as prophylactic treatment or as a along with treatment in invasive infections, does it have any role? So what about what the journal says about the endobronchial instillations? The endobronchial instillations of antifungals, though they have been conventionally done, the newer treatment options which can be given as systemic therapy and lack of sufficient efficacy and safety data to support the use, the endobronchial instillations of antifungal agents should not be used for treatment of aspergillosis, tracheobronchial aspergillosis or invasive aspergillosis. That is the recommendation now. Then what about the percutaneous or intracavitary amphotericin deoxycholate for aspergillosis, either chronic cavitary or solitary aspergillosis, solitary aspergilloma? Though there have been numerous solitary case reports which have described the administration of antifungals by percutaneous catheter, there are some adverse effects which are associated with such administration, with like coughing, fever, headache, vomiting, etc. And there are no definite advantages, benefits, and though clear studies have not been done, so the percutaneous delivery of antifungals is not currently recommended treatment of aspergillus infections. What about aerosols? Now, nebulization of amphotericin B formulations, that is amphotericin B deoxycholate and amphotericin B lipid complex and liposomal amphotericin for the prevention of invasive fungal infections, especially in solid transplant recipients and hematological transplant recipients, along with patients who are on anti-cancer treatment for neutropenia, have been recommended. And that is targeted high-risk populations, that is cancer, chemotherapy-induced neutropenia, and hematogenous stem cell transplant and solid organ transplantations, they have been recommended. The goal is to recommend deliver the high antifungal concentrations of this antifungal at the site of initial infection while minimizing the adverse side effects and drug interactions. There are no uniformity regarding the formulation, dose, timing, and duration of therapy. Various clinical studies have actually reported uses of all those in patients. The doses have been 5 to 10 milligram or 10 to 20 minutes twice daily. This is the usual usage of amphotericin B deoxycholate, which is actually recommended in lung transplantation. That has been a actual recommendation in lung transplantation, so to be given for 6 to 12 weeks. But there are also other combinations, other dosages which are available, like the liposomal amphotericin B 12.5 milligram over 10 to 20 minutes, either daily for 2 consecutive days and then weekly. These are other other dosages which are available. The 2018 European guidelines for antifungal prophylaxis have actually advised this liposomal amphotericin B twice weekly along with the oral fluconazole for patients with high risk of invasive mold infection. But actually, they are now recommended only in patients who are neutropenic. That is the recommendation. So actually the guidelines vary, various guidelines. In contrast, IDSA 2021, 2018 ASCO and the IDSA 2021 both advocate alternative and antifungal strategies with triazoles, inhaled triazoles. So actually the guidelines vary regarding the antifungal agents, and they are rightly now recommended only in patients who are undergoing lung transplantation, the recipients of lung transplantation, as well as patients, transplantation recipients with neutropenia. So not presently recommended mainly in fungal prophylaxis for all transplant patients, and it varies for guideline to guideline. Now, what about the systemic antifungal agents like fluconazole? In systemic antifungal agents, triazoles have been recommended. Voriconazole is usually given for as a prophylaxis in lung transplant patients. Again, in solid transplantations, what is the recommendations? The optimal duration of in the solid transplant recipients, as we have already discussed, the oral triazoles is given, but inhaled amphotericin is still a questionable role. So, but there is a role in systemic therapy along with inhaled amphotericin for anastomotic endobronchial ischemia or ischemic reperfusion injury in airway in tracheobronchial aspergillosis in lung transplant patients. But its role as an ally along with the oral triazoles in invasive infections is still questionable. So invasive infections, whether the amphotericin is really recommended, it is still not fully recommended. It is actually recommended along with the therapy in specific situation in lung transplant patients. That is the role of aerosolized formulation of amphotericin B as an adjunctive treatment for invasive fungal infections has not been established. And the use of amphotericin B in allergic bronchopulmonary aspergillosis is also not well established. There was actually studies in cystic fibrosis, asthma, and HIV patients and in lung transplant recipients, but the randomized control trial, a randomized control trial did not show any effect in ABPA. The adverse effects like cough, dizziness, chest tightness, mild bronchospasm, sputum production, etc., which is more common with the amphotericin deoxycholate preparation, that is actually preceding, and the bronchospasm has to be actually prevented by giving along simultaneous salbutamol nebulization. So there are, except in lung transplant patients and as in tracheobronchial aspergillosis in lung transplant recipients and patients who are neutropenic patients, there is actually no definite recommendation. And data on aerosolites, echinocandins, and azoles are even more limited. There are few case reports actually describing successful use of aerosolized mica fungin and voriconazole into separate patients in actual proven invasive diseases, but there are no randomized controls regarding this. So there as adjunct treatment along for systemic trials in actually documented infections is still lacking. So thank you for the patient listening. So that much about the inhaled therapy.
So extremely lucid presentation, Dr. Sajida. So even though it's a bit exhaustive, it's extremely clear that beta D glucone it's good for those with those who has a high predictive, high pretest probability, and similarly not really great for a low pretest probability. Similarly, galactomannan. And de-escalation is also possible, especially even in those patients who has invasive candidiasis. So that's also a really good news. Of course, there are newer drugs and the newer modalities of treatment in pipeline. I'm sure the drugs like rosafungin will be coming, but endobronchial, treatment modalities are still in vogue, but it has not yet come into the guideline, nor the efficacy has not been proven. So I think the any queries, any questions that has come in the chat box. Vanshu?
No, sir, there are no questions from audience till now.
Then I think shall we wind up the session? Thank you, Sajida. A great presentation. Over to Dr. Unni.
Thank you so much for the entire team. Did a great job. First by Dr. Thomas Kurian, and then followed by Sajida, and obviously Dr. Rajesh. it was wonderful. All of you have done a great job in giving a complete overview of the topics, as well as the journal which you have all chosen for discussion part. I'm grateful to all of you for taking time and being part of Safe Skills Academy. And Dr. Praveen and Paramesh, I know it's so nice for me to be like getting coming back is in fact nostalgic. I really miss the days I was there in Cochin with all of you, and it's been so long. It's more than 10 years now. Yeah, that's all. I'm so happy that now we will have more and more sessions like this. Thank you, Asmita, for being here with us. I know you are there. And thank you, Himanshu from Imagika Health for organizing and making this event in a successful manner. Yeah, all the technology part is taken care. And nevertheless, my friend, Dr. Srivalsan, and once again, Rakesh, for taking all the initiative for taking it forward and making it useful for all the students as well as the entire medical community who wishes to upgrade their knowledge regarding pulmonary medicine and associated topics in critical care as well as pulmonology. That's all from my side. Thank you so much. And Sri, you are there. Over to you. Want to say a few words?
I'm there. I think
Yeah.
nothing much. Once again, thank you from my part. So thank you all for finding your time, sparing your time to attend this meeting. And my sincere thanks to all the speakers and chairs who contributed sincerely to the topics. And see you all with the next session in next couple of months. Thank you.
Thank you. Take care.
So we will wind up the session and we leave. We can leave now. Thank you.
So with your permission, shall I conclude this meeting, sir?
Yeah.
Thank you.
Thank you.
Thanks
Thank you
a
very
lot.
Thank you all. Okay.
Thank you very much. So from here, I'm ending this meeting. Thank you very much, everyone.
Yeah,
Have a good
thank you.
night.
Proceed.